Thank you, Marisa, for joining us from the Alps, which is obviously you're on holidays, and we really appreciate all the work you do in this topic. But Akila, if you can please share your slides, we'll get started with your talk.
Yeah.
And if the other sort of panelists, we'll just mute ourselves and turn our camera off, but leave Akila on.
Okay, can you see?
Working perfectly.
Okay, thank you. Hi, I'm Akila Chandrasekhar. I'm a consultant in tissue and eye services in NHS Blood and Transplant. Good afternoon, everybody, and thank you for giving me an opportunity to join you this afternoon to share our exciting journey of skin banking in the UK. Over the next 15-20 minutes, I'll be talking about how tissue banking has evolved in the UK and the role of NHS Blood and Transplant and the current status of the skin banking and any future development that is planned. And at the end of the day, I'm not here to preach. It's just to give examples how we can apply good practice to establish a tissue bank to suit local needs. So tissue banking has a long history in the UK. In 1960, they were set up by the surgeons as small hospital-based blood banks, usually banking one type of tissue, either bone or skin or heart valve, with the storage facilities serving a single hospital, particularly for the surgeon to meet their patient clinical requirement. In 1980s, these tissue banks sort of merged into large multi-regional banks serving different hospitals they become multi-tissue banks with the different types of graft and specialized processing and storage facilities. In late 90s and early 2000, these tissue banks approached blood service with a view to set up a national tissue banking service. It is because the blood services already had large facility, multiple clean rooms, and they have specialized processing and storage equipment, and they have networking with the hospitals, and they can provide all types of graft needed nationally. The driver for change at that point was particularly the regulation was around the corner, and the blood services had the expertise in quality management system and dealing with the regulators, and so it was an easier option to join with the blood service to set up a national service, and that's what happened. The tissue banks were sort of started regulation in mid-2000, and that is still continuing. NHSBT tissue and eye services, they are a function of the NHS Blood and Transplant, and they provide majority of the tissue graft used in the National Health Service. The main difference between blood donation and organ donation and transplantation is that we are not the sole provider of tissue graft. There are other NHS banks, particularly hospital-based femoral head banks, and also there are commercial imported supply from United States into the country. All tissues are obtained and supplied within the UK. NHSBT operates on a not-for-profit basis. We do charge a hospital for the services, but we don't make profit out of it. It's a cost recovery model. And we are regulated by the Human Tissue Authority and licensed by them. Tissue processing and banking was centralized in Liverpool in 2005, and we are one of the largest multi-tissue banks in Europe. Eye banking in Bristol and Manchester merged with NHSBT in 2015, and tissue retrieval and teams are based in 4 locations: Liverpool, Leeds, London, and Bristol, and they cover the whole of the country. The advantage of the NHSBT model is that the entire clinical pathway from donor selection, consent, tissue procurement, tissue processing, and storage and issue all are managed by one organization. They all come under one umbrella. So in terms of traceability and stock management, it is easier. Different countries operate different models. For example, tissue procurement can be done by donor selection and consenting organization, or it can be done by tissue banking. But in NHSBT, everything is done by NHSBT. The donor deferral, as I mentioned previously, all the donations are voluntary. Donors, the families don't get paid for the service. And the referral can come from different areas, like either come from the direct intensive care unit or A&E, or we have alliance site model where certain hospitals notify us of all the deaths, or it can come from specialist nurses in organ donation or from coroners. All referrals are dealt with by National Referral Center based in Liverpool. We get around 6,000 referrals a year and facilitate 500 multi-tissue donations and probably about 2,500, 3,000 cornea donations. irrespective of whether it's an opt-in or opt-out model, the consent for testing, removal, storage, and use and disposal is taken from the donor families. And more importantly, we do collect only for need. For example, during Olympics in 2012, we were asked to bank 1 million square centimeters of skin for emergency planning, which we did. And then after the Olympics was over the next few years, we would be sort of reducing down the skin retrieval and storage, because to rotate the skin stock, and we will collect only what we issue on a yearly basis. So the donor selection, we follow the human tissue safety and quality regulation, which is a regulatory requirement, and also joint professional advisory committee donor selection guidelines. There is a website available, www.transfusionguidelines.org.uk. And major contraindications in summary include any unknown etiology, malignancy, and any risk of transmissible infections or neurodegenerative disorders. And different tissues have different age criteria, but what we are mainly concerned about is the risk of infection transmission. All the donors, the donor samples undergo mandatory testing for HIV-1 and 2 antibody and nucleic acid testing, hepatitis B surface antigen and hepatitis B core antibody and nucleic acid testing, hepatitis C antibody and nucleic acid testing, syphilis and HTLV antibody. And recently, under SAPTO recommendation, hepatitis E testing was introduced as well. NHSBT and UK Health Security Agency, previously known as Public Health England, we have a joint infection surveillance program. Any tissue donors who test positive, they would be sort of followed up and look for risk factors. And then also that would help us to calculate the residual risk of infection, to inform what is the chance of somebody acquiring infection through a tissue graft that can feed into the patient information leaflet, which is made available to the surgeon, which if they want, they can share the information with the patient to get informed consent. Moving on to skin donation, once the consent and donor selection is passed, then the National Referral Center will pass it on to the retrieval teams. The retrieval can happen in the hospital mortuary, or some hospitals we have agreement to move the donors to the dedicated donation facility in Liverpool and Speak in NHSBT, and we would use that for training purposes if necessary. Donor blood sample maybe has to be taken within 24 hours. That's a regulation. And then also there will be a brief body mapping or physical examination of the donor prior to retrieval. Donation must be completed within 48 hours of death if the body has been refrigerated within 6 hours of death. If not, the time will come down. And the donation is treated like a surgical procedure. Strict asepsis are observed. Skin retrieval is done with the electric dermatome. But if you need like a full thickness, we may have to use a skin knife. The skin is usually taken from the back of the torso or front and back or the thighs. It can be 5 to 15 meter wide, up to 60 centimeter long. Donated tissue is securely packaged and transported on dry ice to Liverpool from wherever, from all over the country, and the body is treated respectively and dressed up and as necessary. Once the tissue arrives in Speak, it can be temporarily stored in the fridge, and then the tissue is, this is the first photograph, the skin is transferred onto a separate pot in the safety cabinet, and pre-processing microbiology samples are taken, and then soaked in antibiotic for 24 hours. And then the following day, it's taken out and rinsed in PBS, and post-processing microbiology is taken, and then the tissue is sort of, as you see here, this is the adding of the antibiotic is the second picture, and then the washing is the third picture in the PBS, and then it's rolled out on the gauze and rolled out into like a separate containers, and cryomedium is added, that's the fourth picture, and kept for 2 to 4 hours, and then rolled on put into a nylon pouch, and then onto the foil pouch, and put it into a controlled rate freezer. Once it's cryopreserved, it can be stored either in the gas phase nitrogen or -150 freezer. In Speak, we do use -150 freezer. This is one way of processing. So the reason for cryopreservation is to maintain cell viability. The question is, do you need a viable skin, or is non-viable skin good enough? Viable means detectable cellular metabolic activity. There is a little, if at all, any direct comparison of performance between viable and non-viable graft. So it's at the end of the day, it's the surgeon's choice. So some centers are happy to use non-viable skin and some centers aren't. So we provide cryopreserved skin as because that's what the surgeons want. The cryopreservation is, as I mentioned, it's a viable graft. It can be stored for a long time without any deterioration, but we give 5-year shelf life because the donor selection may change and the testing requirement change. So arbitrarily, we are giving 5-year shelf life. The disadvantage is that it needs sophisticated facility and equipment. It's not cheap, and there's a low temperature transport is needed. And also it precludes the use of strong decontamination process because of cryopreservation. So the other method, I think, which I know is used in India, is the glycerolization. It's introduced by Euroskin Bank in Holland in 1980s. It utilizes high concentration of glycerol to sequester water content. Glycerolization process is both antimicrobial and antiviral. Long stem storage at refrigerated temperature is possible, so you don't need deep freezers. Advantage is it's safer and easier to store and easier to transport, and it's simple to prepare compared to cryopreserved skin. The other method is irradiation. This was introduced in UK in 2005, and this involves impregnating the skin with a radioprotective chemical followed by gamma irradiation at 25 to 40 kilogray. This results in a sterile, non-viable graft. This can be kept deep frozen. This is safer, but this is again a non-viable skin. In NHSBT, what we do is that we do, as I mentioned previously, we do pre-contamination and post-contamination microbiology sample. In the pre-contamination sample, if there is anything called like a objectionable or rejection organism that are tabled on the right side, that would be a reject for cryopreserved skin. Similarly, in post-decontamination sample, if any microbial growth other than Kin's-Commonwealth would be a reject. That reject means it is not suitable to issue as a cryopreserved skin. So at that point, we will send it for gamma irradiation and use it as a non-viable skin, so the tissue doesn't get wasted. Whatever method we use, the important bit is that the protocol that is used to prepare, store, and transport tissue graft must be validated. So the validation requires that the critical quality attribute has to be defined. It can be sterility, size, biocompatibility. So I'm not a scientist, so I'm not going to go deep into it, but whatever it is, the validation can be done either in-house or it can be relying on the historical data or third-party data, but that has to be, there should be some sort of a local validation. So the important bit is that you have to demonstrate whatever process you use is compliant with the good practice system or GMP. From moving on from the skin, the next product we use from the skin is called a decellularized dermis. The decellularization process removes donor cells and cell remnants. Cryoskin is usually a temporary graft used to cover burn wounds, whereas after taking the decellularization, what we are left with a minimally immunogenic collagenous extracellular matrix. So this is not rejected. This can serve as a permanent implant. This can, in theory, can repopulate with the donor cells, which serves as a scaffold for new tissue. So this, because the decellularization process we use was developed in conjunction with the University of Leeds. It's called a decell, which is a patented process. The Leeds University set up a spin-out company called Tissue Regenics, which owns the patent, and NHSBT has licensed to use this technology in the UK. And we've been preparing skin graft with this process since 2012. We initially did a small case series because this is the first time we were using this process in human use on chronic non-healing wound. This is one of the picture on the right is one of our first patients who had that study showed a very good response. And then we got a National Institute of Health Research grant to do a randomized control. It's a multiple stage study on multiple intervention in diabetic foot ulcer, which is a national study led by Leeds University Hospitals. And then we are also doing a randomized study on venous ulcers in association with Imperial College. There are other small scale study we have concluded is the use of decellularized skin in rotator cuff. This is a thick dermis, whereas in chronic wound it is a thin dermis. Thin dermis can also be used in hypospadiasis revision surgery, scalp wounds, and plastic surgery in scar revision. So there are several indications. We haven't ventured into breast reconstructions and hernia repair, but there are evidence in literature for that. But it takes long time to set up clinical trials and gather evidence. So we started in 2012. We are still gathering evidence of clinical benefits of decellularized dermis on different clinical indications. As I mentioned, that the first and second generation are currently in use, and then the future would be the third generation, where the matrices are repopulated with cells and bioactive molecule in vitro. So that would be advanced therapy medicinal product. So that's all in R&D stage, and probably we have some way to go on that. So I just want to finish my talk with the acknowledgement to donor families who give consent for donation, and our R&D team and tissue and eye services team, and the clinical team of surgeons and users, and of course patients who benefit from the skin graft. My special thanks to my colleague, Dr. Richard Ramas, who worked with me on several clinical studies, setting up clinical evaluation of decellularized dermis. And this is my tissue and eye services team in speak. Thank you.
That was excellent. Thank you very much, Akila. We've got some questions coming through, but we probably usually will save it for the panel discussion when at the end. I'm going to hand over to Dr. Sunil Shroff, who's just going to introduce our next speaker. Over to you, Sunil. Thank you.
Thank you. Thank you, Dale. Our next speaker is Dr. Sunil Keswani, who is a plastic surgeon from India. He is the medical director of the National Burn Center in Mumbai. In fact, he is following his father's footsteps. His dad also was a plastic surgeon of great repute. Dr. Keswani is a champion for skin banking in India. He has set up 12 skin banks in India. He is also the representative for Southeast Asia for skin banking. So Dr. Keswani is going to talk to us about established skin banking in India, and he's going to talk about his experience. Welcome, Dr. Keswani. It's good to have you here. Please, you can share your screen and get started. Thank you.
Thank you so much, Dr. Shroff. It's a pleasure to be talking to such a wide audience globally. And here I go ahead and share my screen.
Working perfectly. Thank you, Dr. Keswani.
Thank you for acknowledging. It's always nice to have a feedback that the screen is on. Sometimes you start off without the screen. The topic for today is skin banking in India as we see it. India, as we all know, is a fairly diverse country with a very rich cultural heritage, with a population of about 1.4 billion. Now, India records about 7 million burn injury cases annually, of which 0.14 million people die every year. It is worthwhile stating here that 50% of these could have been saved if there were enough skin donors and enough skin banking facilities in the country. Incidentally, around 70% of all burn injuries in India occur in the most productive age group, unlike many other countries. This is between 15 and 35 years of age. Around 4 out of 5 burn cases are women and children. Most of the accidents happen at home. And as many as 80% of cases are kitchen-related accidents. Now, what is skin banking? As my previous speaker mentioned very, very clearly and elaborately, skin banking essentially is a facility where skin is collected from the eligible deceased donor and processed as per international protocols We follow the protocol of the Euro Tissue Bank in Netherlands, and this can be used to resurface wounds. Skin can be stored as per the glycerol technique that we use for about 3 to 5 years. Now, the uses or indications of the skin allografts, the utilization happens in majorly in burns, where the large burn areas required to be resurfaced to get the wounds to start healing. In major orthopedic trauma, where there are degloving injuries. In non-healing diabetic ulcers, to prepare the wounds prior to definitive autografting or resurfacing. In trophic ulcers and pressure sores as a preparatory measure before autografting or resurfacing with flaps. And in certain skin diseases where the skin gets exfoliated, like in toxic epidermal necrolysis syndrome, epidermolysis bullosa, and the like. The various skin banks in which we have set up in India, we have about 6 skin banks in Maharashtra, that's a state. Another state has got 2 skin banks, Karnataka. Odisha has 1. Haryana state has got 1. Madhya Pradesh 1 skin bank. Tamil Nadu 5 skin banks. 12 have been set up by us, National Burn Center, and 4 others function independently. Totally, there are 16 skin banks in our country. Now, why is glycerol preservation more preferable in the Indian subcontinent? Essentially, because glycerol is easily available, it's cost-effective and reasonably inexpensive. There's an ease of transportation of skin in glycerol from our center to the other centers which require the skin, which sometimes is a flight journey or air journey of about 4 to 6 hours. There's less antigenicity because it's basically a non-viable skin that we have vis-a-vis the viable skin following cryopreservation. And the glycerol technique maintains the extracellular matrix and the elastin fibers, which are essential for the graft to take. The effectiveness of this glycerol technique works because the glycerol is a cryoprotectant. It's a decontaminant in the sense that it is virucidal and bactericidal. It acts as a preservative and is essentially non-toxic. The glycerol has to be washed off completely. We wash it 3 times in saline before actually using it. Now, what is the organization of this tissue banking in India? Essentially, there's a central body based in Delhi, which is the National Organ and Tissue Transplant Organization called NATO. And India has been divided into 5 regions, which calls the 5 regional organ and tissue transplant centers are there. So 5 ROTOs are there. Then the 29 states have 29 SOTOs. SOTO is State Organ and Tissue Transplantation Organization. And there is another body called the Zonal Transplant Coordination Center, ZTCC, which essentially looks after allocation of tissues and organs once they are ready. Now, this is the distribution. As you see the 5 regional organ and tissue transplantation organizations on the left, which are the centers. And on the right side, you see the states, which each ROTO covers them. The National Burn Center is registered under the SOTO, that is State Organ and Tissue Transplantation Organization. And we follow the guidelines of Euro Tissue Bank from Beverwijk, that's the Netherlands. India, as I mentioned a little while earlier, 0.7 million people get burnt, and most of them are from the lower or middle income strata. And early excision and use of glycerol-preserved human skin allografts is the gold standard treatment for burn wounds to ensure good morbidity, lesser morbidity, and better survivals. So hence the need for skin banks. Skin Bank at the National Burn Center, which I'm the medical director of, was started in 2009 with collaboration and help from the Euro Tissue Bank in Netherlands. And since then, 14 more skin banks have been set up all over the country. We have our partners at the Rotary Club of Leiden, Amsterdam, the International Rotary Partner, Rotary Club of Bombay North, that's a Mumbai partner, and the Euro Skin Bank Amsterdam is a technical collaborator for our skin bank. But this is the infrastructure of the skin bank that we have. To start off from left to right, you have the administrative office here, which is very important because the documentation happens here. The cold room, this is the outer view where the skin is actually stored at 4 to 8 degrees centigrade. This is a skin processing room where there's a biosafety cabinet where the skin is the phase 1, phase 2, and phase 3 processing is done. This is the outside room, which has got the kit storage. There are 6 kits ready at any point in time, and we can service 4 skin donation calls simultaneously. We have 4 teams ready. This is the biosafety cabinet, the external view, the internal view. This is the Shakem incubator for lubricating the skin in glycerol prior to preservation at 4 to 8 degrees centigrade. This is the hot air oven. This is the microbiological testing incubators. And this is the inside view of the cold room, where you see on the stands, the skin is kept in polycarbonate bottles, and each person's skin, donor's skin, is kept in a separate plastic squarish container. the whole hierarchy of the skin bank consists of the skin bank director, who essentially is a plastic surgeon, general surgeon, either of them, but who is actually actively involved in treating burns. And the skin processing team consists of biotechnologists, a pathologist for serological testing, a microbiologist for microbial analysis, and a skin retrieval team consists of 4 people. They go for the call. It's either a doctor or a biotechnologist. In India, it's allowed for a biotechnologist to go and harvest skin, so long as he is certified and trained at a center which is known and recognized for skin banking. 2 paramedics, either nurses or assistants, ward assistants are sent. And 1 assistant is generally an ambulance driver who helps in carrying things to the site of skin retrieval. That's either the skin is retrieved either at the home where the patient has died, or in the hospital where the patient has died. Or sometimes we go and harvest skin from the mortuary. Now, these are the various aspects of skin banking. Handling of the burns helpline. The call comes in for the burns helpline. The quick response time. We have a 20-minute response time for the team to leave the hospital after receiving the call. The skin harvesting done at home or in the hospital. Transport of skin from the home where it is harvested or the hospital to the skin bank. Processing done at the skin bank. Storage and documentation of the skin which is harvested. Distribution of the skin harvested to the appropriate recipients after checking the credentials. Documentation, overall audit of the whole procedure, and this ensures quality control. So all in all, this is our personnel at the hospital receiving the skin bank call from the relatives or an NGO, a non-governmental organization, which gives us the call. After confirmation of the call, the kit is again checked finally. It's always checked and kept again rechecked. It's kept sterilized. The team leaves with the kit. We have specialized skin bank ambulances for taking the team to the site of harvesting and getting the team back to the skin bank. The procedure is divided into 4 stages: the retrieval, the harvesting of the skin, the processing of the skin, the storage of the skin in appropriate conditions and 85% glycerol at 4 to 8 degrees centigrade, and then is the distribution of the skin. This is how the skin is harvested with a dermatome, as Ms. Chandrasekhar just mentioned to us. The body is cleaned with beta scrub, antiseptic solution there. And the skin harvested with the help of the dermatome, the measurement of dimensions of the skin harvested, how long is the strip, how wide is the strip, and the area is calculated, what is the area of the strip. Length into breadth gives us the area, as you all know. The skin is meshed or kept as sheet graft. The meshing is done 2:1 in a Brennan measure. Microbiological testing is a regular part of the protocol, phase 1, phase 2, phase 3 processing stages. Each skin strip is kept in a separate polycarbonate bottle in 85% glycerol. And the skin is transferred over and once it's trimmed and measured and kept in the walk-in fridge. This is how it's kept in the walk-in fridge. Here, the courier person has come to take the skin, and it'll go by air, by flight to a different hospital in a different state, several kilometers away. These are our statistics for skin banking, skin donation as we started in 2009. This is from 2010. Initially, we used to get 2 donations a month, about 24 donations in a year. And gradually, the numbers kept rising, went to 62, 113, 230, 261. As more and more awareness programs were conducted, as more and more people came to know that skin is also a tissue, organ which can be donated, more and more people were willing to donate. In India, we have found that people essentially are wanting to donate. They are willing to donate, except they are not aware that skin is a tissue which can be donated. So essentially, the onus is on us, medical personnel, to create awareness among the lay public and doctors and medical personnel and healthcare workers. Yes, the skin is a tissue which can be donated. And we have reached a plateau here. Of late, in COVID times, the numbers dropped precipitously to 69. We diverted, kind of ricocheted back to 156. And since the beginning of the year, we have had about 15 donations. Numbers are a little less again, because there are certain apprehensions in the minds of people as to the safety protocols followed as regards COVID. So this map of India shows, the colored area shows where all are the areas where our skin bank services the needs of the other burn centers. They are the areas where we send skin from our state, Maharashtra, to Madhya Pradesh, to Gujarat, Telangana, Karnataka, Kerala, Uttar Pradesh, West Bengal, Tamil Nadu, and Delhi. So we have been sending skin by courier whenever we have excess beyond what we need for our needs to the other states, other burn centers to help their patients. Now, these are the statistics of, in blue bar diagram, you find the amount of skin procured. In red, you see amount of skin used. Essentially, whatever skin comes in gets used almost immediately. with the glycerol technique, that's our technique that we use at the National Burn Center Skin Bank. It takes 45 days to complete the phase 1, phase 2, and phase 3 processing. At 45 days, the skin is now ready for distribution. And by the 46th or 47th day, our skin is completely utilized. There's a waiting list for skin, and always the demand far outstrips the supply. There are various non-governmental organizations associated with our bank, and almost 70-75% of our skin doesn't come through direct contacts. It comes essentially through these non-governmental organizations and certain individuals who have devoted their life to creating awareness and helping and convincing people to donate skin. The success story of this whole thing works out. The NGO or the transplant coordinator of hospitals contacts us, the skin bank coordinator, and then the relatives are always convinced by the transplant coordinator or the NGO, and that's how the skin donation ultimately happens. So convincing the patient's relatives or the deceased relatives for skin donation is the key. And once the convincing is done, going and harvesting is the easier part of the job done. So creating awareness is extremely important. So India is a very religious nation, and there are a whole lot of rituals after death. The body preparation is required. There's almost a 1.5 hour body preparation before body is cremated. And there's a lot of myths and disbeliefs that are there. And especially in a city like Bombay, reaching the site of the hospital or the home where the call comes from for skin donation, look at the kind of traffic jams we get in Bombay. And it's very difficult sometimes to reach from one place to the other during the daytime. At night time, it's easier. So though our team leaves the hospital about 20 minutes, to get there sometimes takes 2 to 2.5 hours. So the window period is up to 6 hours that we harvest the skin. And sometimes it's difficult to reach a place in the window period to be able to harvest the skin. In the monsoon, in the rainy season, which is June to almost September, Bombay gets flooded with water and it's very difficult for vehicles to ply. And this is what happens. So the local train transport, the buses and cars cannot move. And then at that time, it's very difficult to get there. In spite of this, we are fairly motivated, and our team is motivated, and in spite of the high traffic, in spite of floods, in spite of deadlines of cremation timings or burial timings, our team reaches there and manages to harvest about 20 donors per month. Now, what are the myths and false beliefs? Essentially, some of the myths are as follows. Skin can be donated when I'm alive. If I decide to donate my skin after I pass away, my body will be skinless and appear red and bloody after the donation. Some people believe that an open casket funeral will not be possible if we have donated skin. Some people believe that doctors won't attempt to save me when I'm critical if I am registered as a tissue donor. A lot of people believe that if skin is wrinkled, it cannot be donated. Some families believe that if they donate their relatives' next of kin's skin, they would have to pay some money for it. There is no charges actually involved. And last and least of all is my religion discourages organ and tissue donation. So when the religions all came up, there was no question of organ donation happening at that time. So there is no there is a community called the Jain community, and 95% of donors are from the Jain community. During COVID times, our team wore complete personal protective equipment. They were completely clean, prepared, and draped the body completely. They wore caps, masks, and gowns, double masks. And a proper history was taken of the deceased person, travel history in the previous 1 month. Contact with infected and suspected cases was reviewed. Symptoms, whether they had symptoms of respiratory disease, were checked up before actually going for the harvesting. And at the time of harvesting, a nasopharyngeal and oropharyngeal swab was taken by the healthcare worker. So I think all these precautions being followed, we did manage to do a few, but lesser number of donations during the COVID period. We did not actually stop, except for 3 months when we did not understand what COVID was all about. But the 4th month, we came back with all this PPE, the protective glasses, the doffing and undoffing, and hand hygiene, and we managed to restart the skin harvesting program. For us in India, the non-governmental organization Rotary has been a big help, and the success of a functional skin bank largely depends on creating mass awareness about skin donation consistently. And this requires significant manpower and financial support, and therefore Rotary comes in, which provides the funding for running these banks. The difficulties were convincing the government, the medical personnel for the need for skin banking. The difficulty was getting funding. The difficulty was creating the infrastructure and training the staff initially when we started. And the biggest difficulty was mitigating the false beliefs and myths that people have in their minds. And lastly, one of the other difficulties, creating mass awareness. Small groups we are able to prepare, create awareness, but large groups, India is such a large country, 1.4 billion population, to create awareness there is a Herculean task. Convincing the government for recognizing skin as an organ or a tissue took us a while. It's only in 2015 that skin banks got to be recognized, though we started much earlier, but without government permission. But we have been subsequently licensed and permitted to run the skin bank. Awareness becomes the key, and different forms of awareness programs we have been doing in the last 13 years that the banks we started in 2009. And essentially, the awareness programs are done in schools, colleges, corporate offices, fire brigade, the fire officer, the NCC cadets, the religious places, in condolence meetings after the person is dead. Generally in India, it's the 3rd day and the 12th day after death. International and national medical conferences, we get an opportunity to talk about skin donation. We hold special car rallies for skin donation, and the newspapers, and we put articles, and the journalists have been very supportive. And certain hospitals and hospital personnel, we go to hospitals and give small talks of 15 minutes on skin donation. Essentially, these are awareness programs at the Rotary International Convention in Atlanta, at the function in the race course, in blood donation camps, we can talk, at the Asia Pacific Burn Congress in Singapore, at the National Conference in Shimla, the NCC cadets awareness, in the naval establishments, among the firefighters, among BPOs. At the condolence meeting, our team goes, we have a big team of about 15 individuals who go and give these talks on skin donation, short talks of 15 minutes, short and sweet. This is for different NGOs, we have been giving talks, car rally, organ donation, in various corporate offices, in schools, colleges, as I mentioned, articles in the lay press, journals, newspapers, and all in all, spreading awareness that we do walkathons, we do cyclothons for skin donation and organ donation. Essentially, it is a thankless job, but we are happy to state that we have made rapid strides in the field of skin donation in Mumbai and in India. And our deepest gratitude is all the skin donors. There's a big thank you from our Skin Bank team to all the skin donors and to all of you for having given us this opportunity to speak on skin donation at this international forum. Thank you, ladies and gentlemen. Thank you very much.
Thank you, Dr. Keswani, for this wonderful overview of skin banking in India and the struggles you've gone through. I know that we still have to go a long way. Most of the states in the country still don't have a skin banking available. And India being a large country, and you show the traffic in Mumbai, how difficult it is to procure skin locally as well. So there is a requirement. The National Organization for Transplant and Tissue Banking is there, but I don't think so they have made so much progress as you have done. So thank you again for your overview. I know that as we go forward in the next 5 years, hopefully more and more states in India will have skin banking. I think what our experience in India is very relevant to other developing countries as well in the Commonwealth countries. So I think it's a huge opportunity for us all to learn from you. Thank you again.
Very, very interesting. I wonder, Marisa, did you want to make any comments before we go to the questions?
No, I just want to compliment both speakers because I think they gave us a very interesting views of different realities. However, there's some very strong commonalities. One is the challenge, or interested by the. I was interested very much to.
You're breaking up a little bit, unfortunately, Marisa.
Yes,
must be
about UK. Can you hear me?
You keep breaking up a bit, which is a shame, but never mind. It's difficult because you're actually on holidays in the lovely Alps at the moment, as we've heard. So.
So I'll leave you for later for the discussions. But basically, thank you for both speakers. It was very interesting presentations, and I might add a comment on the Q&A, which might be easier then. Thank you.
Thanks. We'll read it out. Absolutely. So both Akila and Sunil, there were a lot of questions about trying to sort of promote skin donation and how we can sort of meet the needs of the public. And I'll go to Akila first. We talk a lot about in the UK about we talk about organ and tissue donation, but when we talk about tissue donation, we often think of corneas. How can we do more to sort of get that message about skin banking for you first, and then I'll go to Sunil.
Yeah, thanks, Dale. I was heard the talk of Dr. Keswani with the interest, because in UK for the skin we are in we are not in a position where we are not able to meet the demand. As I said, we can we collect to need, so we collect only what we need to issue the clinical requirement. Because of the health and safety requirement and the number of burns cases are not as high, or road traffic accidents are not that great. So, the demand for skin over the decades have been sort of coming down rather than going up. So we are in a good position in the UK in that we have enough sufficient stock to meet the clinical requirement, and we can manage the stock accordingly. So that's why we are in a position not only to do skin for burns, we are able to expand on to decellularized dermis because for other clinical indications. And also there are bio from porcine skins and other skin which may not be acceptable in India. There are other alternatives as well, which we do not know how good they are compared to human skin, but for example, pediatric, there are a BioBrain that's being used. And so probably Dr. Keswani would know more about it from the burns perspective, but there are other alternatives to human skin as well.
Thank you, Akila. Dave, do you want me to take the next question?
Yeah, we'll just see. Should we ask Dr. Keswani first what he feels, with that sort of promoting, marketing, and trying to get the message of skin out? And then we can please feel free, Sunil, to ask the next question.
Thank you.
Essentially, in India, we have a very good network of Rotary, and Rotary has been helping us create the awareness. They want projects to be done, and each club, there are 115 Rotary clubs in the city of Mumbai, and all 115 clubs do about 8 to 10 programs every year for us. So we are essentially promoting through the network of Rotary, and we're extremely happy. And the whole 10 to 15 minutes for the higher class students, 7th, 8th grade students for skin donation. So we are extremely lucky that in India, people are receptive to skin, eye and organ donation talks. And they are willing to and wanting these talks to happen in schools and colleges and prime the young students and young adults of tomorrow about organ donation.
Thank you. Thank you, Sunil. There's one interesting question from Laurie, and he is asking, why did NHSBT bank extra tissues during the Olympics, Akila?
Yeah, that is a part of, we were asked by Department of Health as a part of emergency planning. Suppose during the Olympics, if there is, say, for example, unexpectedly there's been a fire or accident where there is a requirement for skin. So it's all part of planning process. So they identified this is what we needed to do, and we facilitated that.
There's another question which has, a gentleman, I'm not sure who it is, but the question is about how does retrieving skin in the donor's home work? And further, he's or she's asking, how is sterility considered? And how is the dignity of the donor and family taken into account? They're all mixed up in one question. So first is, how does retrieving skin in the donor's house work? I don't think so. NHSBT does that. Do you do home retrievals, Akila? I don't think.
No, we don't.
We have
to have like a Newton licensed premises, and we can't facilitate it at donor's home. No.
So I think, Sunil, you do a lot of those home retrieval, don't you?
In fact, Dr. Shroff, 80% of our donations occur at home, only 20% occur in hospital. And it is not easy. It was not easy initially to harvest. The moment the person dies in India, the body is lifted from the bed and kept on the floor as part of a religious ritual. So all the harvestings are done at home, and our team has become quite adept at harvesting skin when the body is lying on the floor. I think it's a question of getting used to a particular technique. So it was difficult initially, but we have found out ways and techniques how to harvest this body, the skin from the body at home. And we take not only thighs, but we take legs also here, Dr. Akila. So that's a slight difference from your protocol. We take thighs, legs. They give us about 1,500 square centimeters. If we take the back also, we get an additional 1,000 square centimeters. So generally we take thighs, legs and back. We get about 2,500 square centimeters in a normal, moderately built adult Indian male.
Can I ask another follow-on question, Dr. Keswani? We learned about the 6 hours before the body should probably be in the mortuary. So obviously, if you're doing it from home, you have to be there. How quickly can you get there? I know the traffic jams you showed us. You have to be there within a few hours. Yeah,
generally what we tell them is to extend the window period a little bit by covering the body with ice-cold saline and ice-cold water with ice put over it so that the body is kept cool. And then we extend the window period of 6 hours to about 8 hours. So in the 8 hours period, we are able to reach there. But normally we reach there within the 6 hour window period.
Dale, in India, most of the bodies don't go to the mortuary. Even if the patient die in the hospital, they are transported to patients' homes, or if the patient die at home, they go to the cremation from there straight away. So they don't go to mortuary. Unlike here, if somebody dies at home, the body is moved to the mortuary.
In fact, all the eye banking, also eye retrieval also is done at home. 80-90% of eye retrievals in India happen at home.
But it's easy to do eye retrieval at home compared to skin retrieval. Yeah.
Absolutely. Absolutely.
Well, that is very fascinating for those who were like me watching and listening and didn't know that. So thank you for sharing. There's another follow-on question of, can a person who died of internal organ dysfunction donate their skin? I guess this follows on from a few other questions in the chat about, is it the same as any other tissue for the regulations? Is it the same for an organ? What makes a good skin donor or makes someone who can donate their skin? How does that work?
Can I answer that, Dr. Akila? Yeah. As far as when you're talking of multiple organ failure, so long as the cause of multiple organ failure is not sepsis, it is quite okay to harvest the skin because skin doesn't get affected as such. But in generalized diseases like where there is a malignancy or cancer with extensive metastasis, that's a strict no-no for harvesting skin. Local conditions like fungal infections of the thighs, legs and back, of course, we do not take that. So I think certain conditions you cannot harvest, certain things are contraindicated. But multiple organ failure per se is not a contraindication.
Yeah, it's the same in here.
The one part, which we need to probably answer for all the participants is the question from this anonymous attendee is, how is the dignity of the donor and their family taken into account? I think, Sunil, again, at home when you retrieve, how do you maintain the dignity? This is after the consent, obviously.
Yes. Yes. What happens in India, as it is, the houses are very small. They're very small rooms in Mumbai. I mean, very small rooms, and with just enough space for the team to be there. And normally, we do permit one family member when they insist that they want to be inside the room. So we allow one family member to be there because they're very emotional. And initially, we thought we will not allow them to be inside. But when we did that, the relatives created a lot of noise. They were afraid. They were apprehensive how the donation is going to happen. When the family member comes inside, he watches how methodically the cleaning is done. They watch how methodically we all prep up with cap, mask, gown, and the specialized instrument. We have dermatomes by which we harvest, and then how neatly the skin is taken and kept in the containers, and how nicely and gently the body is covered up with gauze and bandage. They go and tell outside that, yes, they did a good job. It's done neatly. There was no bleeding. There was no problems. So it creates a positive effect, and they talk to others about it. Skin donation is good. They do it nicely. The team is good. So it's a positive feedback that we get and the positive reinforcement for the cause of skin donation.
Thank you. Dale, next.
Yes, there's a question at the bottom of it about if there's no skin donation bank in the state where I live in, I think this is in India, where is it taken? Which skin bank? How is it decided? I guess it's how you organize things. We saw that map, but how do you work it out, Dr. Keswani?
We have 16 skin banks all over the country, and each skin bank services up to 200 kilometers from their skin bank. It takes about 3 hours to reach a place for a perimeter, for a circumference or a kind of a diameter radius of about 200 kilometers all around your center. So the team is willing to go up to 200 kilometers. We travel sometimes, go up to Pune and harvest skin. Pune is about 150 kilometers away. And our team goes in the middle of the night to 150 kilometers away to go and harvest skin. But in the states where there is no skin bank, skin cannot be harvested, unfortunately. That's why our aim and attempt has been to set up banks all over the country through Rotary and through the help that MOHAN Foundation also helps us out. Dr. Shroff's organization helps us. ZTCC helps us. Roto also helps us. And we have reached the figure of about 16 banks. And every year we have been adding 2 skin banks. And hopefully, as Dr. Shroff mentioned, in about 5 years' time, we'll have 10, 20 more banks. And practically every big state will have a skin bank of repute.
Yeah. Can I ask a question? I come from the state of Tamil Nadu. I know that there are about 4 or 5 skin banks there. How many of them are linked to your national network, or how many are like a independent or something? Like that?
Officially, only one of them, the Rights Hospital, Dr. Balakrishnan Skin Bank, is linked with us with an MOU, a Memorandum of Understanding. The other 4 have come up independently in Ramchandra Institute, in Stanley Medical College, one in Kilpauk Medical College. But unofficially, they keep asking advice from us. And they are part, we have set up an Association of Skin Banks of India about 3 years ago. And they are part of the association. We share with them the protocols and SOPs which we have received from the Euro Tissue Bank. So though they're officially not with us, unofficially they follow the same protocol. All over India, the glycerol technique is followed. That's easier to follow and cheaper to follow.
Yeah. Because I know that there was a skin bank in Madurai last month. That's why I asked, because and there is one in Coimbatore as well.
Coimbatore one has been set up by us at Dr. Raja Sabapathi's hospital, which is the Ganga hospital. So that's been set up by us directly. Yeah.
So you go, Sunil, you ask.
Yeah. There's one question asking about what standards are being followed for skin banking in India. Do we have any national standard which are laid down like guidelines and published by NATO as yet, or we haven't done that, Dr. Keswani?
NATO has not done that as yet, but we are in the process of advising them, because we have taken the Euro Tissue Bank guidelines and tweaked them to suit Indian conditions. So we are in the process of collaborating with NATO and set up Indian guidelines. They're not yet out, but very shortly, in a year's time, we should be out with the guidelines.
So
I think developing national standards is very important, isn't it? Especially if you want to maintain the same standards across the country. So that is the next step forward for you.
So while we're still discussing, we will finish at the top of the hour, but we do know we've got people from Singapore, UK, Australia, India, all watching. If you're from a different country than those I just mentioned, just put in your country in the chat so we can just know where we're reaching today. There is one question, and then we'll probably move to Dr. Marisa Herson's sort of summary and see your respective reflections on that. But the simple question, and this shows, I think, the need for us to even people who work in the field to learn more, because I don't actually know the answer to this. If the skin retrieved from a hairy donor, will the recipient translated skin be hairy? And will the transplanted skin change color to that of the recipient's skin?
One must realize, Dale, that the speaker, the person who's asking the question, should realize that skin is a temporary skin substitute. These allograft, as we call it, is a temporary skin substitute. It does a temporary job of preventing bacterial infection happening. It does a temporary job of preventing the exudation of plasma from acutely burnt patients. And essentially, it covers the nerve endings, so the patient's pain disappears completely once you put the allograft onto the patient's burn wounds. This does not remain permanently. So ultimately, this promotes the patient's own skin either to grow back or prepares the wound for subsequent definitive skin autografting. So this skin will not remain there. So this skin has no role to play in whether it's hairy or pigmented. The patient's own skin will come back in the form of self-regeneration from the dermal elements or the auto-transplantation, or what is known as autografting.
Great answer. And I'm learning. Akila.
Sorry, do you shave the skin before retrieval?
Always. The shaving is done. Yeah, shaving is done. Thorough cleaning we did. with detergent is done with the betadine and scrub, and then it is cleaned up with saline twice so that it's nice and clean, like a surgical prep, like a major operation.
And I imagine the 0.3 millimeters is very small and a lot less than I had pictured. So I think some of that, there's a lot of education can happen even for the doctors and nurses like myself.
It's almost one-fifth of the thickness of skin. So it's epidermis and a very superficial part of the papillary layer of the dermis. We don't even go into the reticular layer.
I'm going to move us, if I can, to just going through Marisa's sort of summary and giving some of the global perspectives. I'll just read out what she said and then get both your opinions. I call the attention to a few global common points. How much more is needed, in particular, if need goes beyond day-to-day needs and extends to mass casualties supplied? How long is the overall awareness levels from authorities, professionals, and the public at large? Not to add limited funding, etc., because you often have limited funding. Time to join efforts to develop common tools to better reach governments and health authorities and establish a network. And thank you for a most motivating hour. So as the audience, if you didn't catch at the beginning, Dr. Herson works with the WHO task force on this topic is the General Secretary of the World Union of Tissue Banking Associations. Hopefully, Marisa, I summarized that well for you, your points. But I think if I can go to our speakers, we often hear about the day-to-day use of it and not really building up big banks. It's a bank in the smallest sense of processing and then distributing immediately. So there's no storage of it once it's processed. And then how do we sort of work together, either on a Commonwealth scale or worldwide scale to sort of raise the whole standard across internationally. So should we go to Akila first and then Dr. Keswani?
Yeah, what comes to my mind is that there was a volcano eruption in New Zealand. We reached out to them to offer help if they need skin in those circumstances. I think they've been liaising with other countries as well. So there is a global, setting up this global network is an important point. So people can sort of help each other at the times of needs and disasters. And as I previously mentioned, we did have like a emergency planning before Olympics. Now I was thinking we are going to have Commonwealth Games. We do not know what's going on in the background. And so those kind of networking and working with each other, I personally think is very important. And probably Dr. Keswani would agree with me on that.
Dale, could I make a brief comment, please?
Yeah.
Dale?
Yes, go, Sacha.
Yeah, in fact, I think the Tribute to Life Memorandum of Understanding that we are doing, in that the implementation groups are going to be created. And in my humble view, all implementation groups must have information about skin and tissue donation. This webinar will go a long way. So I think we should encourage everybody in the implementation groups to look at this webinar so that we can give the appropriate information to all our people wherever they are in Commonwealth.
Very, very good. Dr. Keswani, do you want to have the final words before we wrap up?
Yes, going forward from what Dr. Akila mentioned, we do not have any excess. We do not have enough for our present day-to-day needs. Question of handling a disaster and servicing the needs of a disaster is absolutely out of the question. We are ill-equipped to treat disasters. As far as skin is concerned, we do not have enough allografts. So the question of looking after a disaster patients and the large numbers which come with a disaster, we will be very, very ill-equipped. And as regards funding and allocation of funds for creating more awareness, we do not get any funds from the government. And it's organizations like MOHAN Foundation, with Dr. Shroff runs, which are doing yeoman service to create awareness in a fairly large way with this large network of centers. And I think the last word should go to Dr. Sunil Shroff to do.
Not at all, Dr. Keswani. I think, as medical professionals, as Dale said, we learn every time we listen to you guys, on areas which are not our own. And, I'm pretty sure that, in India, in time to come, we will get our infrastructure right, we'll get our logistics right for tissue banking. Our banking is still in a very infantile stage for a large country like ours, be it skin, corneas, bone, and other tissues. We don't have enough. We still import, as you know, a lot of these tissues from abroad for our usage. And that is expensive to the exchequer because the dollar gets stronger, the rupee gets weaker, as you know. And I'm sure this is the same problem with other developing countries as well. So there's a long way to go, but we have made a good start, and we would need, more cooperation. The Commonwealth will come in perhaps and help us in putting better guidelines and better cooperation between regions so that we can help each other to grow better and to be able to deliver to our masses as the need is required. And as far as disasters are concerned, I think if there is a disaster where skin is required, I think with this Commonwealth Tribute to Life Forum now existing, there may be an opportunity for more cooperation if unfortunate such disasters do happen anywhere in the world, at least among the Commonwealth. I hope that in due course of time, with all the members being here, we should be able to formulate some guidelines. Thank you.
Indeed, that's a very powerful message. And at least, through this webinar, even today, the people you need to talk to, you've actually sort of met on screen and met each other. And that's one of the great things. So I'll just close today. I just want to really thank Dr. Herson and Dr. Shroff for being our chairs today, and particularly our two amazing speakers, Dr. Keswani and Dr. Chandrasekhar. This has been, for me, really personally interesting, and I've loved every moment. So thank you for sharing. And just to highlight to those watching that actually the next webinar will be the 17th of May. It'll be 12 o'clock UK time, 16:30 in India, and 2100 in Canberra, Australia. So the same time as this one. And we're going to be doing that topic on donor coordinators, whether that's a donor transplant coordinator, as some countries call them, or SNODs, like we call them in the UK. Please join us for that session then. And thank you, and good morning, good evening, good night to all of you across the Commonwealth. Thanks for joining us today.
Thank you.